Welcome back guys. Now let's continue with the collecting duct. That's the last part of the nephron. Guys, in the collecting ducts, there are two types of cells present. Okay, there are two types of cells. What are the two types of cells present in the collecting ducts? That's the principal cell, and intercalated cell. So in between the principal cells, there are intercalated cells. Inter means in between. So how many types of cells are there? Principal cells and intercalated cells. You can see in the last part of the nephron, principal cells are there and intercalated cells are there. Now what they are doing? Okay, I will tell you. But in the last part of the nephron, some hormones are also acting. Say I haven't explained any hormone so far. No hormones are acting on the PCT and no hormones are acting on the loop of Henle and distal convoluted tubule. I have told you one thing, the parathyroid hormone acts on the distal convoluted tubule, helps in the reabsorption of the calcium. That's fine. But here in the last part of the nephron, two important hormones are going to act. What are the two important hormones? One is aldosterone, that is a mineralocorticoid, and antidiuretic hormone also called as vasopressin, arginine vasopressin. Now, if we complete these two, what aldosterone is doing to the collecting duct and what antidiuretic hormone is doing to the collecting duct, if we complete this, the collecting duct topic will be completed. Now, first let's begin our topic with the aldosterone. Right, aldosterone acts on which cells? Aldosterone acts on both principal cells as well as intercalated cells. We all know aldosterone is a steroid, it goes into the cells. Okay, it crosses the cell membrane. Next, what is a major stimulus? Okay, what is the major stimulus for the release of aldosterone? In which condition do you think aldosterone is released from the adrenal gland? The major stimulus is hyperkalemia. Hyperkalemia. What is the meaning of the word hyperkalemia? Hyperkalemia meaning your potassium levels increasing. More than how much? More than 5.5 millimole per liter or milliequivalent per liter. If your potassium is going more than 5.5 milliequivalents per liter, then it is called as a hyperkalemia. And tell me, hyperkalemia is a major stimulus for release of antidiuretic hormone. So tell me, is it good to have more potassium? No, definitely not. Potassium is going to cause arrhythmias and that can actually kill the patient. So whenever there is more potassium, which hormone is released? Aldosterone. Why? Because see, aldosterone can cause potassium excretion out of the body. Aldosterone kicks the potassium out of the body, trying to bring the potassium back to normal levels. So now tell me, aldosterone, what it is doing? See, when aldosterone is acting on the principal cell, see, aldosterone is crossing the cell membrane because it's a steroid, it's coming and binding with the intracellular receptor, or you can say intracytoplasmic receptor. Okay, whenever there is aldosterone, what these principal cells are doing? The principal cells are reabsorbing the sodium but kicking the potassium out of the body, So the sodium is getting reabsorbed with the help of a channel called as ENaC channel, epithelial sodium channel. This is the one name which you have to remember. So aldosterone with the help of epithelial sodium channels increases the sodium reabsorption, causes the potassium excretion. But when the same aldosterone, when it acts on the intercalated cell, see, it will also come and act on the intercalated cell. Now what these intercalated cells are doing? Causing the acid excretion. So done. So right, my dear students, aldosterone, when it is acting on principal cells, two things will happen. What is that? Increasing the sodium reabsorption. So sodium is getting reabsorbed. And at the same time, potassium will be excreted out of the body. So what will happen? The potassium levels will decrease. So aldosterone increases the sodium levels, but the same aldosterone decreases the potassium levels. Then what about the intercalated cell? Intercalated cell, sir. When aldosterone acting on the intercalated cell, there is more proton excretion. Protons are going out of the body, acid is going out of the body. So acid excretion. When there is acid excretion, what happened to the acid levels in the body? H plus levels decreases. Okay. So let me write here also for better understanding. Increases sodium reabsorption and increases potassium excretion. So what is the final result? As the potassium is getting excreted, the final result is decreased potassium in the body. And what about the sodium? Increase sodium in the body. So these are the final results. So sodium is getting increased, potassium and acids are getting decreased. Done. Now, let's see some important points regarding aldosterone which you already know. All steroids, not only aldosterone, cortisol, testosterone, okay, estrogens, they're all steroid hormones have the intracellular receptors. True, you already know this. What about the aldosterone? Yes, aldosterone is also steroid. So it is having intracellular receptor where? In the cytoplasm. So having intracytoplasmic receptors, very important. Next up, have I taught you the epithelial sodium channel activity is regulated by which hormone? The ENaC activity, epithelial sodium channel activity is regulated by aldosterone. So I can say whenever there is aldosterone, the ENaC will function. Whenever there is no aldosterone, ENaC should not function. This is normal. But what if these epithelial sodium channels are doing overactivity? Means they are now doing overaction, guys. Okay, the epithelial sodium channels are doing overactivity. So now what will happen? This overactivity is going to cause a syndrome called as Liddle syndrome. Guys, remember Bartter syndrome, defect in TAL. Gittleman syndrome, defect in DCT. Now I am talking about Liddle syndrome. Liddle syndrome is a defect in collecting duct. Fanconi syndrome, defect in PCT. Okay, again, let's come in the order. PCT defect, Fanconi syndrome. Loop of Henle, that's a TAL defect, Bartter syndrome. DCT defect, Gittleman syndrome. Collecting duct defect, Liddle syndrome. Okay, so now Liddle syndrome, it is an autosomal dominant disorder. Okay, autosomal dominant disorder. Overactivity of which channels? Epithelial sodium channels. So now this epithelial sodium channel, what it is doing? It is doing the overaction. Okay, so let's try to understand it like this. If one of your friend or like in a class, if one student is doing like some like a mess, all others will also follow the same. Okay, if one of your friend is a naughty guy, you will also automatically become naughty. In the same way, this epithelial sodium channel will start to do the overactions. Try to understand, even these channels will also start to do the overactions. Okay, when more sodium is coming into the cell, when more positive charges are coming into the cell, in order to maintain the balance, more potassium will automatically go away. So if one channel is overactivated, all other channels also as a compensatorily doing the excessive activity. So now you tell me, what happens in Liddle syndrome? Sir, these channels, they are overactive. So what will happen to the sodium reabsorption today? There will be more sodium reabsorption and there will be more potassium and more acid excretion. More potassium and more acid excretion. More sodium reabsorption. So now tell me, what are the clinical features that are going to be seen? The clinical features, sir. The clinical features. Because of the excessive sodium reabsorption. Okay, because of the excessive sodium reabsorption, what will happen to the BP? There will be hypertension because sodium increases the BP. Next up, what happened to the potassium levels and acid levels? Decreasing potassium excreted, acid excreted, leading to hypokalemic alkalosis. Now stop. Where we have discussed about the hypokalemic alkalosis? Just go back. Okay, just go back and check here. In Bartter syndrome, look here. In Bartter syndrome, there is hypokalemic alkalosis. In Gittleman syndrome, see there is hypokalemic alkalosis. But Bartter and Gittleman are hypotension disorders. Look here, hypotension, and Bartter also hypotension. But what about the Liddle's, guys? Liddle's is a hypertension disorder. So look, Liddle syndrome is a hypertension disorder with hypokalemic alkalosis because of the overactivity of the channels. Fine. In Bartter and Gittleman, there is more polyuria, water loss, dehydration. But in Liddle syndrome, there is no such dehydration seen. Dehydration is not seen because this is not a sodium losing disorder. This is a sodium gaining disorder. No dehydration is seen. And how you are going to treat this condition? Treatment is simple. Who is doing the main overaction? Epithelial sodium channel. ENaC channels are doing overactivity. So let's block them. So the drug is ENaC blocker, epithelial sodium channel blocker. The name of the drug is called as amiloride. Okay, amiloride. Right. So amiloride is the drug that is being used. So now my question to you, when RAS pathway is activated, tell me whenever there is a hyponatremia and hypotension. Okay, low BP, hyponatremia activates the RAS pathway. But in Liddle syndrome, already the patient is having hypernatremia and there is a hypertension. So do you think RAS pathway is activated? No, this hypernatremia and hypertension actually inhibits the RAS pathway. RAS pathway inhibited. So what happened to the renin levels? There are less renin levels. What about the aldosterone levels? Less. So aldosterone levels are going to be very, very less. So that is precisely the concept. That's the precise point is, so here there is no aldosterone. Without aldosterone, which channels are doing overaction? Epithelial sodium channels. So in Liddle syndrome, always remember aldosterone levels are very, very less and epithelial sodium channels are doing overaction. Even without aldosterone, they are doing overaction. Okay, done. So look at this. In Liddle syndrome, aldosterone levels are reduced. Why aldosterone levels are reduced? Because of the inhibition of RAS pathway. RAS pathway inhibited. Now look at this question. Hypertension disorder with the hypokalemic alkalosis is seen in hypertension with the hypokalemic alkalosis. Is it Bartter? No. Is it Gitelman? No. Is it Fanconi? No. It is Liddle syndrome. Because I have told you all others are hypotension disorders. Okay. Bartter syndrome, water loss. Gitelman syndrome, water loss. Fanconi syndrome, PCT not working, water loss. All of them are going to present with dehydration and hypotension. But Liddle is present with hypertension. Okay. Done. This Liddle syndrome topic completed. Now, let's discuss about the Conn syndrome. You guys are already experts. Okay. We have discussed about this Conn syndrome in the endocrine also. So, what exactly is this Conn syndrome? Students, look here. Here I am showing you the adrenal gland. Let's say this is adrenal gland. Okay. So, now adrenal gland cortex. See, in the adrenal gland cortex, there is a tumor called as adenoma. So, this is adrenal adenoma. So, what this adrenal adenoma is doing, what this tumor is doing? See, it's a benign tumor, but 24/7 it is releasing aldosterone. So, it is releasing excessive amount of aldosterone into the blood. So, can I call it this condition as primary hyperaldosteronism? So, Conn syndrome, it's an example of primary hyperaldosteronism. Okay, primary hyperaldosteronism means there is more aldosterone. So, now you tell me, aldosterone is the one which maintains the sodium levels. But whenever there is so much amount of aldosterone, what happens to the sodium levels? The sodium levels are going to increase. What about the potassium levels and acid levels? Potassium level decrease, acid level decrease. So, leading to what? Leading to whenever sodium is not there, see, whenever there is more sodium, what happened to the BP? There will be more BP, hypertension. Okay, hypertension. What happened to the potassium and protons? Decreasing. So, there will be hypokalemic alkalosis. Okay, hypokalemic metabolic alkalosis. So, now tell me, where we have seen the exact clinical features? The exact clinical features are seen in hypertension, hypokalemic alkalosis, exactly where we have seen in the Liddle syndrome. See, hypertension with a hypokalemic alkalosis. Here also, hypertension with a hypokalemic alkalosis. So, now tell me, exactly Conn syndrome is looking like a Liddle syndrome. But how to differentiate between them? How to differentiate? The difference is the aldosterone. I have told you, in Liddle syndrome, aldosterone levels are going to be less because of the inhibition of RAS pathway. But here, look, the main problem itself is hyperaldosteronism. There is more aldosterone. So, look at here. So, in both Liddle syndrome and Conn syndrome, there is going to be hypertension with the hypokalemic alkalosis with the inhibition of RAS pathway. In both the conditions, RAS pathway is inhibited. Okay, so lower renin levels will be seen. But aldosterone levels are elevated in Conn's because of the tumor, not because of the RAS pathway, because of the tumor, and reduced in Liddle's. Okay, so difference is aldosterone levels. So now you tell me how you are going to treat this condition. The treatment of this condition is blocker, aldosterone blocker. So there is a lot of aldosterone. So what you have to use? Aldosterone antagonist. So the drug we are using is aldosterone antagonist called as spironolactone. Okay, spironolactone. The side effect of this spironolactone is gynecomastia. Side effect is gynecomastia. Okay, that's the side effect. That clear. Next, see, sometimes, okay, in Conn syndrome, the sodium levels can be normal also. So, it can be elevated. The sodium levels can be more because of the high aldosterone, or sometimes the sodium levels can be normal. Now, students will be thinking, sir, why it is normal? So, there is aldosterone, right? Aldosterone is trying to increase the sodium, right? Okay, it's trying to increase the sodium. But why in Conn syndrome the patients may present with normal sodium levels? The reason is aldosterone escape phenomena. What is this aldosterone escape phenomena? Let me tell you. Let's begin from here. Let's say Conn syndrome. Okay, Conn syndrome. In Conn syndrome, there is more of aldosterone. There is more aldosterone in Conn syndrome. True. What aldosterone will try to do? Aldosterone will try to increase your sodium levels. Will try to increase the water reabsorption because of the sodium. More water can be reabsorbed. There can be more blood volume. Okay. So what I am trying to say, in aldosterone, Conn syndrome, there is a lot of aldosterone. Aldosterone increases our plasma sodium levels. That sodium can increase your blood volume. Now tell me where this blood volume is going. This blood is going to the atria. Now the lot of blood is going to the atria. Now atria will recognize, oh my god, there is lot of blood. There is lot of blood volume, which is definitely not good for the heart. Definitely not good for the body. It can lead to edema also. lot of fluids are building up in the body. So now immediately the atria will release atrial natriuretic peptide ANP. Okay, ANP, atrial natriuretic peptide. See, in the name itself is there, it's coming from atrial natriuresis, causing natriuresis, that is sodium loss and water loss. So this atrial natriuretic peptide causes the sodium excretion as well as the water excretion. So now you tell me what is happening. Aldosterone on one side, it is trying to increase the sodium, but atrial natriuretic peptide is trying to bring back the sodium back to normal. Aldosterone is trying to increase the blood volume, but ANP is trying to decrease the blood volume by excessive urination. So it's just something like husband and wife. Husband on one side is earning, trying to build something. But what wife is doing? Wife is spending. So there is a balance. So there is no growth. In the same way, here on the aldosterone trying to increase the sodium levels, increase the blood volume, but atrial natriuretic peptide is kicking the sodium out of the body, kicking the water out of the body, maintaining the levels normal. So that's why, because of this aldosterone escape phenomena, the sodium levels can be normal also sometimes because of the ANP. So now you understand the aldosterone escape phenomena. Who is escaping? The body is escaping. Okay, the body is escaping from the effects of aldosterone. So there is no excessive blood volume, there is no edema, there is no hypernatremia, means the body is trying to escape by producing the atrial natriuretic peptide. So now try to understand. Look here, aldosterone and atrial natriuretic peptide both are antagonistic hormones. One will try to increase the sodium levels, try to increase the blood volume. Other will try to decrease the sodium levels in the body, trying to decrease the blood volume. Okay, they are antagonistic hormones, opposite acting, like wife and husband. Okay, so with this successfully what we have completed? We have completed the Conn syndrome. We have completed the Liddle syndrome. Liddle syndrome treated with ENaC blockers, Conn syndrome treated with spironolactone, which is a aldosterone antagonist. Also, we have seen the two important types of cells in the collecting ducts, that's principal cells and intercalated cells, and how aldosterone is affecting their activity. So with this, the topic of aldosterone is completed. Okay, aldosterone action on the collecting ducts is completed. Now in the next video, we'll be discussing about how this antidiuretic hormone is going to act on the collecting ducts. Okay, that will be discussed in the subsequent videos. Hope the video is helpful. Thank you.